Okay, so some reasons, and I think you're familiar with these, but just to get a level set start, why hypertension is important. It's obviously common. If we define it over at 140 over 90, roughly 80 million Americans. If we define hypertension at 130 over 80, over 100 million Americans are affected by the problem. Obviously, we all know that hypertension control is good for patients, and when we don't control the hypertension, they have adverse outcomes, obviously cardiovascular, but there's also evidence that our mental sharpness declines with poor blood pressure control. So it's important for patients to have consistent control, not just intermittent, but consistent control. The nice thing about MAP is we've tested it fairly extensively, and it leads to a rapid, that is in less than 6 months, substantial improvement in blood pressure control. And unlike many other quality improvement programs, it appears that that improvement is sustained over time. We've looked out a year and sometimes even more and see that most of the gains in the first 6 months are sustained. The other reason is it focuses on 3 key process items. The guidelines, which are very nice, but it's been estimated that in primary care, if we followed the guidelines that applied for all the patients we see each day, it would take about 22 hours. And that's why we often get criticized in primary care about not doing everything that's evidence-based. Well, we simply don't have time to do everything. So MAP focuses on 3 key steps. We'll go ahead and look at the next slide. If I focus your attention just on the red bars for the moment, this is 16 primary cares, family medicine clinics in the South Carolina upstate. These were, just standard usual primary care clinics with all the challenges of staffing and some turnover and new electronic record systems being implemented. But in these 16 clinics, their hypertension control at baseline was 64%. And you see a 10% absolute improvement over the first 6 months, during which they were trained in the M, A, and P components. After 6 months, the training stopped, but we continued to give them monthly reports on their process and outcome metrics with patient-level data so that they could identify which patients were meeting the process metrics, which weren't, and then being able to manage that population. Next slide. So let's start with the blood pressure measurement. We know it's important. It's a life and death vital sign, but unfortunately, it's been called the casual blood pressure, and oftentimes it's measured casually. There are 2 major challenges in getting the proper clinical blood pressure measurement. One is getting a measurement that reflects the pressure that's actually in the artery. So we use an indirect method to assess the pressure in the artery, either by detecting Korotkov sounds or by detecting the vibrations and translating those vibrations into the blood pressures. The other major challenge is getting a blood pressure in the office that reflects usual daytime blood pressures. The average blood pressure during the day appears to be a better predictor of outcomes for many patients than the casual office blood pressure. So getting an accurate and representative blood pressure represent the challenges in the clinical settings. Next slide. So on the left-hand side, you see some of the common errors, and not that we make all these mistakes every time, but in most patients, we make at least one of these mistakes in almost every measurement. So when it's been looked in primary care settings, 95% of the measurements are not made according to the standard recommendations we see on the right, with the patient seated, back supported, feet on the floor, arms supported at roughly heart level, a cuff that's appropriate size, in a patient's that resting and not talking and not being talked to. So if we do these things, we avoid some of the errors that are shown in the blood pressure effects there. Next slide. Now, if you have a device called an automated office blood pressure device, and these are automated devices that are programmed to take 3, some of them will take up to 6 readings. We believe 3 is enough. The staff put the device on, activate the device. In this case, I think an Omron may have been used, or it may have been another device. You see 3 listed at the bottom there that have been approved by the Canadian Hypertension Society. The first blood pressure is taken with staff in the room. This is an average of 50 hypertensive patients. Notice the next 3 blood pressures with staff out of the room. Now, this is what happens on average. Some patients have a greater fall, some have a lesser fall. But 20 to 30% of patients that were initially hypertensive by our usual readings are no longer hypertensive when these repeated, more careful blood pressure measurements are made. If you don't have the automated office blood pressure, it's fine to repeat the manual reading. Just make sure to follow all of the recommendations for taking an accurate blood pressure. Next slide. So for the automated office blood pressure, if the initial pressure is elevated or above your goal, if you have a 130/80 goal, obviously use that. Most of us in clinic are still using 140/90 as our definition of hypertension and aiming to get the blood pressure below that level. Obviously, we want the patient comfortable. That includes emptying the bladder if it's full and uncomfortable. Ensure the patient's in a quiet place and properly positioned, all the things we just discussed. The device can be activated. Staff walk out of the room. The blood pressures are taken, 3 of them at 1-minute intervals, 1 minute of rest. It takes about 5 minutes. It's important to redesign workflows so that the staff have something to do with that 5 minutes of time and don't lose that time. And then come back in, and generally what we recommend is to enter the average of the 3 blood pressures, and the automated device is shown calculate the average for you. If you want to enter all the separate readings, that's fine. But what we know is this automated office blood pressure correlates better with daytime ambulatory blood pressure than does the usual office blood pressure, and reduces or eliminates the white coat effect in most patients. Next slide. So here's just some data from some of the clinics that we worked with, those 16 clinics I mentioned. So in this case, 34% of the patients, you see a little over 2,000 had their automated office blood pressure done. 34% of them were no longer hypertensive on AOBP. So their blood pressure on average fell from 147 to 129, a fall of 18 systolic. 66% of patients, both blood pressures, the usual and the automated, were high. Notice their blood pressure on average fell only 6 millimeters of mercury. Now, ideally, and this is a little complicated, and I won't overemphasize it, but I want you to be aware of it. The automated office blood pressure, if you're aiming for 140/90, equivalent office blood pressure is 135/85. So if the pressure's that or higher, it really is too high. Now, for the metric, you're still being judged at 140/90, but to do the best for the patient, you would like that AOBP to be less than 135/85. Notice if your goal is 130/80, the AOBP goal is the same. So it's only at the 140/90 that we have a difference. Next slide. So here's the M part in a logic model. The goal is to measure accurately. We want to make sure the patient's properly positioned, that the room is quiet, that we use an accurate device, whether it be manual or automated. And there's now a device list out that you can check, and AMA and AHA have worked on that. That list is growing, but the devices on it are good devices if you're considering purchasing more. Again, the goal is if the blood pressure is elevated, 140/90 or higher, to take a careful reading, ideally AOBP, but you can repeat your manual measurements carefully. And the goal is to get more patients below 140/90. We mentioned the 135/85 for the AOBP. Don't mean to make that overly complicated. Most clinics are still using 140/90. It's just you want to do the best thing for the patient. Next slide. So I'll start going a little bit more rapidly because we want to be more careful on the blood pressure measurement because that's really the focus today. But in most clinical trials, this is the act rapidly portion. Now make sure the patient's treatment regimen is adequate. Patients require an average of 3 or more blood pressure medications to reach their blood pressure goal. Yet when we look in our clinical practice networks, most of the uncontrolled patients are not on 3 medications. In fact, a lot of them are not on 2 medications. You'll hear me talk about half maximum or standard doses. The reason for that is that at half maximum dose, you obtain about 80% of the blood pressure response. You typically don't incur 80% of the side effects. So you get most of the blood pressure response with fewer side effects. So rather than taking the medicine to the maximum dose initially, consider adding a new drug. So if you add another drug at half max dose, you typically get about an 8 millimeter reduction. If you double the dose of their current medication from half max to full dose, your maximum recommended dose, you typically get 2 to 3 millimeters reduction. So a much better effect of adding than doubling medication dose. And that failure of us as clinicians to prescribe enough medication is a barrier to better blood pressure control. Next slide. So there's a reason we don't intensify treatment at every visit, but left to our own, it's probably 8, 9 times out of 10, we don't increase the treatment when the blood pressure is not controlled. And there are a whole host of reasons for that, including that many patients don't want to take more medication. So we need to learn how to discuss that with them in a way that helps them to understand the importance of blood pressure control, because sometimes they'll talk us out of what we know needs to be done for a year or two before we get around, and patients actually can have complications during that period. Next slide. This is one treatment algorithm. You can have others. There are many evidence-based algorithms, but I think it's important as a group that you agree on the general schematic you're going to use for starting and adding medications. Because again, your patient with hypertension often has 4, 6, 8 additional medical problems. If you've got some standard ideas, then you don't have to spend quite as much time thinking about just the hypertension. It leaves time to think about other things. You see the schematic here for younger patients, non-African, RAS blocker, initially CCB as a second step. For African American, age 55 older, notice that is just reversed. So the first 2 drugs are the same either way. The third step, recommend adding a diuretic. Obviously, you've got compelling reasons to do a diuretic. You could do it sooner. But this is generally a recommended scheme that the British Hypertension Society uses. And I'll show you in a moment another reason to consider using that schematic. If the blood pressure is not controlled on 3 meds and the patient's taking them, you're made sure that the pressure is accurate and representative, spironolactone is a good drug for many patients, provided their potassium is less than 4.7 and their EGFR is 50 or higher. So if the EGFR, their kidney function is depressed, potassium's a little high, spironolactone is probably not your best 4th drug. Next slide. So this is the accomplished study where they compared an ACE diuretic to a CCB ACE. And notice that over the course of the trial, the patients randomized to the CCB ACE inhibitor had about 20% fewer complications on a relative basis and a 2% absolute reduction in cardiovascular morbidity and mortality, which is one reason to consider starting with the CCB-ACE combination. There are all kinds of arguments about what could be done differently if they'd select different drugs and different doses. The reality is the blood pressure control was within 1 millimeter for both of these regimens. So it may not have been explained by a blood pressure difference, but by the type of medication difference. Next slide. These are just examples of some generic meds that are often inexpensive. Again, I think the important thing is that you have some idea of what you want to use, make sure that the medications are readily available to your patients, and either free or very low cost, because cost of medicines out of pocket is a key determinant of longer-term adherence. Next slide. So again, we talked about 3 medications at standard dose if the patient's uncontrolled. Obviously, they're controlled on 1 or 2 meds. We'd not add a 3rd or 4th med. It's for the uncontrolled patients. Complementary antihypertensive medications have additive blood pressure lowering effects. When you use single pill combinations, the only way they get those approved is if there's additive hypertension effects. Now, when we select regimens on our own, unfortunately, sometimes we select regimens that don't have additive blood pressure effects. So the single pill combinations have already done that work to prove that. Again, 80% of the blood pressure lowering benefit is obtained at standard or half maximal doses for most medications. Adding a blood pressure med at standard dose lowers blood pressure 3 to 4 times more than doubling the current medicine from standard to maximum dose for most patients. For patients that don't tolerate half maximal doses, you can use quarter standard doses, say of 4 medications, and still get a 20 millimeter or greater reduction in blood pressure. So you have options for patients that can't tolerate half maximal or standard doses. Next slide. So again, the point here is if the blood pressure is uncontrolled, let's think about whether the treatment regimen is adequate. Obviously, it'd be nice if the patient's restricting salt, eating a healthy diet, and exercising. Some patients will, and some patients, for various reasons, cannot do that. Single pill combinations are efficient because patients often count the number of pills more than they count the number of medications, and they often appreciate having fewer pills to swallow. So single pill combinations. Monthly follow-up could be a phone conversation, it could be an internet conversation, could be an on-site visit, but following up monthly for patients that are uncontrolled is a useful strategy for getting them to control. Again, the goal is here, if the patient's uncontrolled, let's think of getting them to 3 medications at half maximal or greater dose as a step in improving control. Next slide. Partnering with patients. So the best blood pressure measurement and the finest treatment plan will not work if the patient doesn't understand or is not engaged in the regimen. There are things that we can do to help engage our patients. Shared decision-making. Patients that participate in their management decisions are more likely to adhere than patients that are not involved. Simply teach back, making sure that what we believe we've communicated to the patient is the patient's understanding, and they can tell us back what it is that they heard from us. In addressing red flags, missed appointments, missed prescription refills. It's not a matter of chastising the patient, it's a matter of understanding what are the barriers that keep them from their appointments or their medications or whatever that red flag may be. So it's an opportunity to do some problem solving. Self-monitored blood pressure, which you'll probably talk about, and there, I think, a loaner program that may be available to help your patients. Patients that self-monitor their blood pressure get that information back to you, and you pay attention and use it in the treatment decisions, often have very significant improvements in blood pressure control. Self-monitoring the blood pressure and you're not getting the data or acting on it has very little, if any, effect on blood pressure control. So using it as part of the treatment process is very effective. Obviously, we can get patients and families and others, individuals, to help support the changes, good. Low-cost medications, single pill combinations, and refill consolidation. Again, many of our hypertensive patients have multiple chronic conditions. If they have to go to the pharmacy separately for each medication, they're just less likely to do that consistently. So refill consolidation. Next slide. Self-monitored blood pressure, we've already talked about, is a useful tool for engaging patients whose blood pressure is not controlled, particularly if they relay the data back to you and you use that data to help guide the treatment decisions. Next slide. Single pill combinations I've already talked about. In general, adherence is better with single pill combinations than separate medications. Data suggests not only is adherence better, but blood pressure control is also better. And there's emerging data suggest not only is adherence better and blood pressure better, but patients actually have fewer cardiovascular events with single pill combinations than separate medications. And we did mention refill consolidation, trying to reduce the number of visits to the pharmacy to get all necessary meds. Next slide. I haven't mentioned much about lifestyle. We have limited time, but this is a slide about low intensity physical activity. It's just not being sedentary, getting up and moving 6 minutes an hour. And people who otherwise sit 8 hours a day can lower the systolic blood pressure around 14 millimeters. So if your patients are completely sedentary, getting to move 6 minutes an hour can make a big difference. And also true for their blood glucose as well, and reducing risk for diabetes. So completely sedentary people, if you can get them less sedentary time and moving, significant health benefits. Next slide. These are just some websites that have available materials. You already may have materials available. Some of these are American Heart, American College of Cardiology, ADA, and others. If your patients are interested in apps, I think there are some on the left-hand side that are good for weight loss or general lifestyle changes. But it's good to have some patient materials that engage them and are appropriate for their education level. Next slide. So again, map 3 processes, measure the blood pressure accurately. We've talked about how to do that. If the blood pressure is not controlled, and particularly if it's more than 5 millimeters from goal, consider adding a medication at half max dose or standard dose, particularly if they're on only 1 or 2 meds at the time. Partnering with patients, shared decision-making, teach back, self-monitored blood pressure. Monthly follow-up does not have to be an on-site visit. Engaging family or friends if you can, and lifestyle changes that are reasonably easy to make and sustain are keys to getting blood pressure control. If you're able to implement these three metrics, you will see a rapid and we believe sustained improvement in blood pressure control because these are three efficient steps that have been shown to give good results. So I think that's pretty much the last slide, and let me stop there. And I haven't been watching the time, so I'll take guidance from my friends at American Heart about how we are for time, but I'll stop here.
We have time for one or two questions. If anybody has a question for Dr. Egan, please feel free to raise your hand and I will take you off of mute. Sarah, go ahead. You are off of mute. Oh, I think.
Can you hear me?
Yes, there you are.
Sarah White for Family Medicine. I was wondering if you ever recommend starting patients on combination therapy right off the bat, since most patients do require multiple medications.
Yeah, I really like that. It's often recommended if the blood pressure is, more than 10 to 15 millimeters from goal. The JNC7 said 20. But if the blood pressure, let's say 10 to 15 millimeters from goal, one of the things I like to do is start a low dose single pill combination. And then most of those have multiple doses, but just take them from quarter dose to half dose. So let me just give you one example. If you were starting amlodipine benazepril and ACCB, you could start at 2.5, 10, titrate it to 520. It's easier for patients to do that. They've still got one pill. You haven't increased the number of pills. And if you need to go to 1040, you could. But patients seem to tolerate that better than increasing the number of pills. So yes, if the blood pressure is 15 to 20, I would go ahead in most patients and start at the 520 rather than the 2.5, 10. But absolutely, I like that strategy. And if you're comfortable with it, I think it's an excellent way to get to control more rapidly. And that's encouraging to a lot of our patients, not precipitously, but more rapidly.
Thank you, that's helpful.
And then we have one more question from Brenda. You should be off mute.
Okay, good. That was an excellent presentation. Thank you for that. I'm in the process of standardizing our stroke prevention clinic so that all providers will pretty much follow the same guidelines when lowering blood pressure. When we have stroke patients that come to the clinic, I usually won't change a medication or add a medication on one visit. If they come in and they're like a 150 over 90 or 160 over 90, I will send that patient home with instructions to monitor that blood pressure twice a day, in the morning and in the afternoon, and for at least a week. And we'll have our nurse follow up for the serial blood pressure readings. And so if those blood pressures are elevated, we usually ask patients to follow up with their primary care doctor, because when you're being discharged from the hospital for stroke as a stroke provider, we're seeing them 2 to 3 months out and maybe again in a year.
Mm-hmm. Okay. Yeah, I understand that. I think it's important when that's done, though, to be very clear in the communication with the primary care provider. What I've seen sort of from the specialty side and from the hospital side is the experts sent the patient to me on these meds with his blood pressure. Maybe that's what they want. If you indicate what the goals are and perhaps the need to titrate, I think that's better than not communicating that. So I've seen it work both ways. Yes, they're the primary care. They should be seeing the patient more often. But if the experts haven't taken the action or communicated clearly the plan and the goals, sometimes primary care is reluctant to intervene.
Yeah, I do think that's happening a lot when the patients are discharged, but as you know, it gets kind of lost somewhere in the shuffles, maybe just a miscommunication. But what we like to start doing is maybe participating in lowering those blood pressures. But
Yes.
You bring up an excellent point. There has to be direct communication, because a lot of times patients are going to their primary care doctor and like, okay, he changed this medication or he changed that medication. I stopped taking it because it was way too expensive. and then we'll start them back on something that's less expensive, and then have to follow up with the primary care. So I guess what I'm seeing, there's not a lot of good transitioning of care and follow up. So to your point, you know, I will do more follow up.
Yeah, it takes time, but for the patient, it's really incredibly efficient, because exactly what you said is what happens to too many patients. And we know those stroke patients are at high risk for recurrent stroke, and we have reasonably good evidence that better blood pressure control reduces the risk of stroke and other cardiovascular events. So communication is really important. Agreed.
Thank you so much for your presentation, Dr. Egan. Dr. Egan is going to hang around with us for the remainder of the hour. At this time, I'd like to transition to have Dr. Shields share a bit of what Holy Cross Health is doing in alignment with the MAP framework. Dr. Shields, you should be off mute.
Yes, I am. Thank you very much. And thank you, Dr. Egan, for such an excellent presentation. And so my goal is, in the 5 or so minutes that I have, is to give an overview of how we took the MAP Target BP program, implemented it in our practices, and really tried to focus on patient engagement. Before I give you that overview, I just wanted to let you know what our practice demographics look like. We're in Montgomery County, Maryland, Silver Spring, Maryland, and a majority of the patients that we serve are undocumented immigrants, individuals who may not have access to Medicaid, who are living without access to a lot of resources, so very vulnerable population. I would say about 75% of our patients are Latina women who have multiple comorbidities, as well as about 25 to 30% of our population within our 4 practices have hypertension as a diagnosis. And so when we were introduced to the AMA program, I was very impressed with the standardized evidence-based approach to lowering blood pressure. So the first component that we had to tackle was confirmatory blood pressure readings. To me, this was probably one of the most difficult things for us to address and get compliance with from a provider perspective, because oftentimes the providers wanted to do their own blood pressures using the manual way versus the automated blood pressure cuffs, or they didn't want to wait for the 5 minutes to confirm that the blood pressure was true and accurate. So we had to do a lot of change from the standpoint of the culture of the providers within the practices. We went from about 10 to 15% compliance with the confirmatory blood pressure reading to now all 4 of our practices have over 90% compliance. That is remarkable, knowing where we came from, but it was a very systematic approach where we had to look at the data on a regular basis and give feedback to the providers. The person who triggered the confirmatory blood pressure readings were often the MAs who took the initial blood pressure. Then if it was elevated, they would have to put the patient in a situation which it was calming, relaxing, make sure that the blood pressure was taken correctly. 5 minutes that we took, 5 minutes from the initial blood pressure reading to get that confirmatory blood pressure. And so the drivers for this were the MAs. We had to not only give the providers feedback, we had to look at the built environment within our health centers, making sure that the blood pressure is going to be taken correctly. We sometimes had to put a stop sign on the exam door so the providers won't go in to rush the visit. But also from a patient perspective, as they saw us changing what we are doing, they expected that. When they came in, they would make sure that they themselves had gone to the bathroom, emptied their bladder, that they were positioning themselves correctly. So that first component of the program to me was critical before we were able to move on to the second and third. Because of a lot of our patients were uninsured, we work with a local organization to get medications for our patients because they oftentimes could not afford the medications. So we looked at the combination medications that were recommended and actually advocated for those medications to be put on the formulary so that we were giving our patients the medicines that were recommended. I also worked with the hospital that oftentimes discharged patients to our practice to make sure the medications that were being discharged or being prescribed were the same medications that we were using. So it became more of just a provider-focused energy for the second step of Act Rapidly, but making sure that we have all players at the table so that once we prescribe the medicines, the patients are taking them. The last step, which was the patient engagement and the patient as your partner, to me, was actually the focus on the first step and the second step. We had to really have the patient feel that they were a part of this process and not that we were doing something to them or doing something for them. So we had already established contracts with patients with other chronic diseases like diabetes. So we started to implement contracts with patients saying, our goal is for you to do this. Your goal may be different, but let's meet midway. Let's see what we can do to get to your goal and our goal as well, which is a clinical goal. For the patient, it might be, I just want to be able to go to work every day or not feel this way or do X, Y, and Z. We also implemented nutrition education that was focused on being culturally sensitive, knowing that oftentimes we say eat healthy, but when you have individuals coming from different countries, there's different taste buds and different things, and we can say, here's asparagus. If someone doesn't know how to fix asparagus, then all we're saying is this is asparagus. So looking at working with the patient from a culturally sensitive perspective, overall, I think what has sort of kind of put a little hitch in our plan is COVID-19. When COVID-19 came, the work that we were doing sort of came to a halt because we transitioned to telehealth visits. And so we had to look at how can we then get blood pressure monitors into the homes for most of our patients so we can continue monitoring their blood pressures. So we're at the point now, you know, we're 14, 15 weeks into dealing with COVID and also dealing with telehealth, where most of the visits that we have patients are not face-to-face. So that has actually put a halt in the confirmatory blood pressure readings, but it's not put a halt in our commitment to working with the patients. And even now, more so than ever before, having the patient as a partner in the process of controlling their blood pressure is critical. So we're focusing on not loaning, but giving a lot of our patients blood pressure monitors that are automated, standardized monitors to use at home. The only issue, obviously, we're relying on them to report the accurate blood pressure measurements. So we're still working through that. But I think what COVID-19 has taught us is that we have to pivot very quickly, think about what we're doing. Don't leave it, but how do we incorporate this intervention into a new mode of care delivery? And I think I'll stop there and answer any questions.
Thank you so much, Dr. Shields. Does anyone have a question for Dr. Shields? I know she only has a minute or two. Brenda,
if I may just offer a brief comment, this is Brent. Your ability to translate the evidence base into practice for resource-limited patients is really excellent. And I hope a lot of people ask you and talk to you and learn more about how you've been able to do that. I think having the patient involved in the process of their care, even at the M&A level, so that you've already established that partnership is terrific. And understanding their challenges and helping them to overcome those collaboratively, I think is just an excellent model. It does take some time initially, as you said, but I think it gets more efficient as people get accustomed to a new way of doing things.
Brenda, you're off.
So, Dr. Shields, that was an excellent presentation. I really enjoyed that. There were two things that I liked. I liked the nutritional education based on culture. I think that is key to reaching out to the population that we serve. One thing that I was quite curious about was, did I hear you mention you gave automated monitors, blood pressure monitors to patients?
Yes, we are actually in the process of giving a lot, not all of them, more the high-risk patients, the patients that we see where their blood pressure has been uncontrolled, but those who've been engaged and coming on a regular basis, we are actually going to be giving them blood pressure monitors. And we got this funded through this local organization who wrote a grant to get home monitoring equipment in light of COVID-19. So blood pressure monitors were just one of the things that we received. We received thermometers, pulse oximeters, nebulizers, scales. So, but we were maximizing on the fact that we are focusing on those patients who have elevated blood pressure. And so we're asking for more of those machines to be provided to us so we can distribute them to our patients. Clearly, one of the things we have to focus on is educating them on how to use it properly. Again, how they should be doing it in the home or being done in the office, and then making sure that it's calibrated well so that they are getting true, accurate readings that can reflect what's happening with them.
Yeah, I'd like to talk to you more offline about the funding for the blood pressure cuffs, because I think that
Sure.
is very important for patients for follow-up.
Great. I believe my email can be given to anyone who has follow-up questions by Jaleesa.
Yes, I'll make sure to share that. Thank you again, Dr. Shields.
Thanks.
So at this point, oh, I'm sorry. At this point, we want to open it up a little bit for discussion. We, prior to you registering, asked a few questions, and then in the poll that we did in the beginning, only about 25% of you indicated that you had been trained or retrained on blood pressure measurement within the last year. So we at AHA are really focusing on what your blood pressure policies look like as far as it relates to training your staff, retraining your staff, making sure that those skills stay fresh. So if any of you would be willing to raise your hand and come off mute and tell us a little bit about how you ensure that your existing blood pressure policy is something that is dynamic and updated and actionable, that would be wonderful. So please raise your hand if you have a comment that you'd like to share with the group, or maybe a question for the group that we can talk through together. Sarah, you should be off mute.
Yes. Hi. Thanks. So I am at Greater Baltimore Medical Center, which is a community hospital outside of the Baltimore area in Towson, Maryland. And we have a pretty big network of primary care offices. There's 11 sites. I happen to be the lead physician at the on-campus site. But we have, so between all of our offices, we have a lot of medical assistants, and we have a nurse who is in charge of making sure that competencies are done on a very regular basis with our medical assistants. They do them once a year, and they are individually assessed by her, as well as I think some other staff members, in terms of their process, how they measure blood pressure, and they're basically taught to do blood pressure sort of as the last vital sign. If a patient's blood pressure is ever over 140/90, they will, because we do all manual blood pressure readings, we don't do automated cuff in our practices, but they will put a laminated sign on the keyboard so that when the physician comes into the office, they'll see that, just an extra visual cue that blood pressure needs to be repeated, because we're trying to, improve our metric of hypertension control. So often we do find that repeating that blood pressure is many times better. And if it's not, we just pay a little extra attention to it. Those are just some brief things that we're doing. I'll say one more thing is we do a lean daily management process where we present different measures at each office to administrators at the hospital in an effort to improve things day to day. And so many practices have used that opportunity to improve blood pressure processes on a regular basis. So for instance, in my office, we used the second blood pressure reading as our LDM quality measure. And if any patients were missed from the day before, we sort of have to decide, how did that fall through the cracks? Why wasn't the blood pressure repeated? And other offices are doing similar things. I know there are some of my sister practices who have a nurse that will actually have times during the week where patients will just walk in for blood pressure checks for those who are uncontrolled. So lots of offices are utilizing this kind of thing to improve blood pressure control overall. The use of automated blood pressure cuffs, I'm definitely going to bring up with my administrators, because it's sounding like that might be really worthwhile to do in the offices. Thank you.
Thank you for sharing, Sarah. Do any of you have stations within your settings where patients or individuals could come in and measure their blood pressure without a clinician?
I do not, and I would love to hear it if anyone does.
And Sarah, one more question for you. The things that you mentioned, were all of those steps written into your existing policies, or is it as you learn, you are implementing things?
Which part? You mean everything is very standardized in terms of how we train the medical assistants and the medical staff. So it's all just part of our standard work procedures. So that's all been written in. Now, in terms of how each individual office is working on improving blood pressure control, that can vary. So each office might implement something just slightly different, and then we share with each other when we have success.
Awesome. I did want to ask the group, for those of you who are encouraging your patients to monitor at home, those who have the resources to do so, how do you make sure that you're able to close the feedback loop? So folks are monitoring their blood pressure at home. How are they sharing those numbers with you? Is it at their next visit? Is there a mechanism in between visits that you're able to find out how they're doing? Brenda, you are off mute.
So like I said earlier, we're giving them basic paper with the blood pressure, explaining the systolic, the diastolic, asking them to take it in the AM and in the PM. We have a nurse that works in our stroke prevention clinic, and she's following up at the parameter that we suggest. It's usually 1 week out, and we're asking those patients to maybe scan it over or send it over. A lot of patients in the population that we serve, they don't have computers. For the ones that can send it by computer or track in an app, we recommend that, because you can track in the app and then have the app emailed over. So the follow-up is done by a nurse. We're also asking them to bring their blood pressure cuff to clinic so that we can track that. Again, this is not a standardized process. This is something that's happening maybe with 1 or 2 providers, and it's not consistent. So, I would like to standardize it throughout clinic for all.
Got it. Thank you, Brenda. I did want to circle back. So as you all are registering for this training, we shared that we are really interested in how you all are documenting these policies. Many of you identified that you do have written policies around how blood pressure culture within your clinic setting or your hospital setting. And we are asking you to look at your existing policy and ask if it can be, how it's being implemented successfully, how you ensure consistent retraining of existing staff. Is there room to make it more comprehensive? And by comprehensive, we are talking about the MAP framework. So does it touch on accurate measurement, training for your staff to make sure that they're measuring accurately, the act rapidly portion, and then again, the partner with patients area as well. So we were fortunate to get some grant funding, so we are able to support organizations who share updated comprehensive blood pressure policy with us by June 23rd with some materials. So what we have are some of the Omron Series 5 blood pressure cuffs. We have the positioning posters. These are meant for your clinical spaces. We have their poster size and they're laminated. And we also have access some complimentary keys for the Target BP Achieving Accuracy. It's a blood pressure measurement training. So it's typically $25, but we are able to, through some grant funding, offer some keys. Does anyone have questions about the policy, what you have to do as it relates to these resources that we have available? Feel free to use the chat box or raise your hand.
So Delisa,
Yes.
Delisa, so most clinics now, I know all of my clinics are telemedicine now, and that's the path that we've taken it, and I don't know how long. Any suggestions how we could utilize these wonderful resources through telemedicine?
So we are learning as we go. During COVID, AHA has been working with our community partners to figure out how to best support. So far, the few folks that we've gotten resources out to, we sent them to their clinical sites, and the clinics have navigated how to get the resources to their patients. If anybody has navigated how to get resources to their patients and is willing to share, please share some of your tips of how you've been able to make that work during times of COVID, because that's been one of our biggest challenges, is getting the resources that we have available to the folks who need them, because AHA is also remote from home. So navigating the things that we have in our office to get to you all in the community it's been challenging, but we are definitely willing to work with you to figure it out.
And just to address again, the deadline for submitting an amended policy in order to receive the items that Jaleesa just mentioned is June 23rd. If you have questions, or if you're starting at the ground level and do not currently have a policy in place, we are more than happy to work with you to develop that. And for those who do have policies but want to enhance with the MAP framework, we too can work with you to incorporate those components. Our contact information will be made available following this call, Jaleesa's and mine. So we just wanted to let everyone know that we're here to help in any way we can, but the deadline would be June 23rd.
And I just opened up one more poll. We do want to get an idea of those of you who are interested in looking at your policy, updating it, and getting it back to us. As Kim said, we have a number of resources that we're going to share following this call, to include these slides and this recording. And so we will be following up with everybody. But if you would like to indicate in the chat box that you want to talk to us more one-on-one about your policy and support between now and the 23rd, please do so in the chat box, and we'll make sure we reach out to you specifically about that. And then the last thing that we wanted to mention was Target BP. Target BP, again, is a joint effort between the American Heart Association and American Medical Association. We have a number of tools and resources that are available to you through Target BP. The MAP framework is just the tipping point of the resources that we, the evidence-based resources that we utilize and share. So again, we will be sending out resources. Target BP is one of those things. And if you're interested in more information about Target BP, how to submit data, and how to receive national recognition from the American Heart Association and the American Medical Association, will also be sharing that information. And then here's our contact information. Both myself and Kim are here and available to you all. And we will, again, send out these resources. If you have any questions that we did not address, please feel free to reach out to either one of us, and we will we will get back to you. Great news is everybody voted in the affirmative to looking at their blood pressure policy and getting it updated. So that is great news. We are happy to hear that. Any last thoughts, Dr. Egan or Kim, before we end today?
No, just a brief comment again. I think this has been a really good session. I think the opportunity to follow up and learn more. This is a collaborative learning. We look at this as a collaborative learning. We learn hopefully from each other and together chart a better and more efficient path that leads to greater success for our patients. It's been a very encouraging session. Great to hear what's happening in the clinics.
And I echo Dr. Egan's sentiments. Thank everyone for joining. It was a really productive conversation and a jumpstart to what I think will be an opportunity for us to really look at blood pressure policies and how we can make them more robust so that we are serving the community as best we can. So thank you guys for joining, and we look forward to continuing conversations with you.
Thank you, everyone. Have a great day.
Thank you.